Welcome everyone to the Alzheimer's 101 conference with Amanda Hughes. Before we get started, I just wanted to tell you a couple things you could do. During the conference, you can raise your hand if you have a question. You can also type in a question. And at the end of the conference, there will be a slide that comes at the very last slide of the presentation. Will give you instructions on how to sign in for the post-test. If you are not at your own computer, you need to copy down the link to the SurveyMonkey post-test, and that is how you'll get your certificate. You have to answer 10 questions and successfully complete the questions, and then I will be sending you out a certificate within a week of the time of the conference. This conference is being recorded and will be available for on archive later on, and we will send out an email once it's archived to let you know. Okay, if we're ready to go, I wanted to introduce Amanda Hughes from the Alzheimer's Association. Take it away, Amanda.
Good morning, everyone. Thank you so much for asking me to be your presenter today. Lisa, I really appreciate the honor.
Conference has been muted.
This information is beneficial for not only the professional caregiver, but also for the family caregiver. So I hope that what you learn today you'll be able to take back to the family caregiver and share that information so that it will make their journey a lot easier to bear, hopefully. So we'll go ahead and go to the next slide. And what I wanted to start out by showing you are the 2012 Alzheimer's disease facts and figures. Around February or March of each year, the Alzheimer's Association releases the newest facts and figures, and unfortunately every year these numbers grow. They're greater. They increase tremendously. Right now, every 68 seconds, someone in America develops Alzheimer's disease, and this past week I was fortunate enough to attend the National Alzheimer's Advocacy Forum in Washington, D.C., where I learned that every 4 seconds, someone in the world develops Alzheimer's disease, which is just incredible to me. By mid-century, someone in America will develop the disease every 33 seconds, and I'll tell you why that is in just a second. But right now, Alzheimer's is the 6th leading cause of death in the USA of individuals 65 or over, and about 5.5 million Americans have Alzheimer's disease. Now, 1 in 8 of people 65 and over have it, but half of all Americans 85 and over have it. So as I'm looking at the names on the side of this webinar today, and I'm looking at everyone who's on the call, if we were all 85 years old or over, I could safely estimate that about half of us would have Alzheimer's disease. By 2025, the number of people 65 or over with Alzheimer's disease will increase to 6.7 million people. One of the reasons for the great increase, just a huge increase, is that the baby boomer generation has reached retirement age. As of January the 1st of last year, every single day, 10,000 baby boomers retire. It's estimated that 3.5 million people age 85 and over will have Alzheimer's towards around 2031. So just wanted to give you these facts and figures that you could keep in mind. I know this is a lot of numbers to wrap your head around, but keep in mind the prevalence of the disease and what we're looking at. This next slide I wanted to share with you. It's really impacting. Let's see if I can get it to change. Oops, went too far. This is a visual that I like to share at every presentation. Between the year of 2000 and 2008, 66 Alzheimer's disease is up. 66% death rates that are occur as a result of Alzheimer's disease. While you see these other 5 causes, which of course are obviously very important, very near and dear to some of our hearts. Those death rates have declined. They have gone down as much as 29%. So we're seeing stroke, prostate cancer, breast cancer, heart disease, and HIV. We're seeing folks who are dying as a result of these diseases. We're seeing those increase. But we saw Alzheimer's disease deaths decrease. We're seeing deaths related to Alzheimer's disease increasing by 66%. So this is just an incredible, incredible number. The reason being for this, just to note, Alzheimer's disease does not receive funding from federal government, as much funding as these other causes do. We do receive some funding just this year. As a matter of fact, in February, President Obama has allotted $50 million to Alzheimer's research, and he actually gave that to the National Institute of Health. We are asking, the Alzheimer's Association and our advocates are asking that he allot $100 million more in research, not including the $50 million, so that we can go ahead and do a lot of research as to what causes the disease so that we can stop it and we can prevent it. I want to explain to you the difference between dementia and Alzheimer's disease, because that's probably one of the most common questions. And it's very easy to understand if you put it into the perspective of dementia being the umbrella term. And dementia, of course, is a general term for the loss of memory and other mental capabilities that are severe enough to interfere with our daily life, and they're absolutely noticeable to the individual and to others. So dementia being the umbrella term, as you can see on the visual, Alzheimer's disease is the most, Alzheimer's disease and Lewy bodies disease, frontal temporal dementia, vascular dementia, those diseases are types of dementia. Alzheimer's disease is the most common form of dementia, and it comprises about 80% of all diagnoses of dementia. So it's safe to assume that if someone receives a diagnosis of dementia, it's probably Alzheimer's disease because of that 80% presence. However, it's possible that the dementia could be among the other 20% of dementias, and I will talk about those next. There are some irreversible types of dementias, and there are reversible types. So I wanted to talk with you first about the irreversible types of dementias. These are dementias that we do not have a cure for. We can't stop them. We can't prevent them. All we can do is manage the symptoms and slow the progression as much as possible. I mentioned that Alzheimer's disease is the most common type, so we have that listed at the top, followed closely behind by vascular dementia, which is also called multi-infarct dementia. That's dementia that results from strokes. Mixed dementia is one or more, or two or more dementias present at the same time. Parkinson's disease is considered a dementia, so you nurses, it's not uncommon for you to have a patient who has a dual diagnosis of Alzheimer's disease and Parkinson's disease. So we would say that they have mixed dementia. Dementia with Lewy bodies is another type of very progressive dementia. It is quite rare. And physical injury to the brain. This is traumatic brain injury. So anyone who receives has significant trauma to the brain, their risk for developing dementia actually increases, especially as they get older. Huntington's disease and, of course, Pick's disease are two other irreversible types of dementia. So while we've talked about the irreversible types that can't be cured just yet, and that can only be slowed, there are some types of dementia that are reversible. There are different symptoms that occur in individuals that can cause what seems like dementia, especially as we get older. And what I always tell family members, I always tell them, take your loved one to the doctor and have them check off this checklist of all of these reversible types of dementias to make sure that the individual is not experiencing one or more of these issues that can be treated. And then, of course, that dementia-like symptom will be reduced and go away. So, of course, adverse drug reactions, infections like urinary tract infections, and as professionals we often refer to that as UTI, and those are very extreme. They're very hard on the body. As an individual without dementia, if I were to develop a UTI, it'd be very hard for me to not be very confused and very upset. So you can see that it does cause extreme confusion as the person gets older. Depression, brain tumors, vitamin deficiencies, anytime we have problems with our thyroid, if we have imbalances there, even constipation and impaction can make the person feel so bad and so uncomfortable that it does cause confusion, and this confusion and short-term memory loss and problems with reasoning and judgment that can all look like dementia. Obviously, we talked about head trauma such as traumatic brain injury. We mentioned brain tumors earlier. Anytime you have anything that sets in and affects the cognitive abilities, we're talking about issues happening. So anytime the brain has something that's not supposed to be there, it will definitely affect the functioning. So electrolyte imbalance, in layman's terms, dehydration. So being dehydrated can make you what we call loopy or lightheaded. As the individual grows older, dehydration can look like dementia. So this is a checklist of all of the different things that doctors check off, make sure to rule out before administering a testing for dementia. On the next slide, I want to illustrate to you a lot of famous faces. You might recognize 2 or 3 or 4 of them. And I want you to know that Alzheimer's disease, it's a disease of the brain, and the brain is very individual to each of us. Alzheimer's disease does not discriminate, obviously, against gender, race, nationality, ethnicity, color, creed. It doesn't discriminate. It can happen to anyone. Of the most notable faces, I'm going to see if I can draw with reds and circles here. If you'll know Etta James, she just recently passed away from complications of resulting from her leukemia, but she did also have dementia. We have Rita Hayworth right here. Rita Hayworth actually was diagnosed with younger onset Alzheimer's. Sugar Ray Robinson, famous boxing great. There's Scotty. I can't remember his name, but I know Scotty. He beamed several people up all the time on Star Trek, but Scotty had dementia. President Ronald Reagan, he developed Alzheimer's disease and was probably one of the first faces to actually, one of the first celebrities to come forward and say, hey, I have Alzheimer's disease. He actually wrote a letter to the American citizens describing his illness and was very, very instrumental in bringing attention to the cause. Charlton Heston, Rosa Parks, Ralph Waldo Emerson, Burgess Meredith, that's Mick from Rocky, and very recently, country music star Glenn Campbell, who is now on his farewell tour. He recently performed at the Grammys and did a very, very, very good job with his hit Rhinestone Cowboy. Last year, how many of you recognize legendary college basketball coach Pat Summitt? She's incredible. She's the most winning coach in basketball, college basketball history. She's even won more titles than Coach K, who is also a legendary coach. But Pat Summitt I had the pleasure of hearing her speak at our National Alzheimer's Advocacy Forum in D.C. this week. I saw her in person. She and her son Tyler were present, and Maria Shriver presented her with the Unison Sergeant Shriver Award. It was just very poignant to be there and to see her. So this couple here, that's my grandparents. That's my Mimi and Pawpaw. And the reason that I am doing what I do today, for 7 years I've worked with Alzheimer's and dementia, because my papa developed Alzheimer's disease and he lived for 16 years. He was the city treasurer of Columbus, Georgia for 41 years. He was a pastor at a local church. He was an incredible man. He was the patriarch of our family, and it was very debilitating for everyone to watch his decline. So the reason that I am doing the work that I do is especially for my grandparents. And I was one of 10 grandchildren, and I was always reminded that I was the favorite, so even before his Alzheimer's. But moving on to the next slide, in the interest of time, I just want to move right along and get into a little of the details about Alzheimer's disease. The rate of progression does vary for each individual. It does cause impaired memory, thinking, behavior issues. I'll show you exactly why in just a second. I mentioned to you that my grandfather lived for 16 years with Alzheimer's. However, the rate of decline is approximately 3 to 20 years, with an average of 8 years. And eventually each person with Alzheimer's becomes incapable of caring for themselves and must have extra help, either from the family caregiver or from the professional caregiver such as yourself. This next slide, I want to show you exactly what Alzheimer's disease does. I want you to see the, I'm waiting on the visual to change. Let's see, okay? I want you to look and see what the brain looks like. If we were to look under a microscope and we were to take a look at the brain, you can see these neurons. The neurons are, they are made up of the neuron cells here, and these feelers, these little branches, are called dendrites. So what happens is you have signals that are passed from one neuron to the other, and that's what controls all of our metabolic functionings. It's how we repair ourselves. It's how we, the neurons communicate with each other to keep our brain functioning healthy, so that we can think, feel, breathe, move, everything. Our brain controls everything. So if you introduce something like Alzheimer's disease, which are these proteins that make up plaques and tangles, here's the tangles here, which are made up of these tau, T-A-U proteins, and then we have beta amyloid proteins, which make up a plaque that coats the neurons. And what happens is that beta amyloid, I'm just going to abbreviate it here, beta amyloid coats like plaque that you would develop on your teeth. And then so if you have a healthy neuron that's passing along a signal to an affected neuron, that signal is going to hit, it's going to bounce off of that waxy coating of the protein, and it's going to go elsewhere. It's not going to get where it needs to be. So that's why it's not uncommon for someone with Alzheimer's to pick up their toothbrush, and instead of brushing their teeth, they might put it in their hair so that they brush their hair instead. So that signal is just not getting where it needs to be because of the buildup of those proteins. The next slide is I wanted you to see a slice of the brain. If we took a slice of the brain and then we divided it between the two hemispheres, you can see that on the left, here's a normal person's brain. On the right, here's an Alzheimer's disease-affected brain. And obviously, you can see that you have the shrinkage that happens because of the proteins killing the neurons. It causes the brain to shrink. It causes the ventricles to also shrink. The cortex, which is the real meaty, supple part with the folds, it starts to really just weaken and shrink and decline. Alzheimer's disease is the type of dementia that begins in the hippocampus area. And the hippocampus area is right here. The hippocampus is the control room for short-term memory. So when you have dementia that begins and you can see direct effect to short-term memory first and foremost, then you can assume that the person probably has Alzheimer's disease. Although other types of dementia do affect short-term memory, Alzheimer's disease affects short-term memory first and foremost because it does develop in the hippocampus region. Moving along to the next slide. As you can see in the previous slide how the Alzheimer's physically affects the brain, then you can understand that if we have brain activity happening all throughout our brain, Alzheimer's is going to affect the way that we read when we're reading the words. As you're looking at these presentations and you're reading what is on the screen, as you hear what I'm saying, you've got activity that's happening. As you think about what I'm saying, you're processing the activity right here in these regions here. As you're saying, maybe you pick up and answer a question or ask a question and I answer it. So we have brain activity that's happening throughout the brain. When those plaques and tangles start to build up, they start in the hippocampus area, and they start to spread, it starts to affect every region of the brain, and eventually we see a decline in the person's ability to function, both cognitively and eventually physically. As the person declines, they venture through three main stages of Alzheimer's disease. They are made up of the early stage, which is you'll see some decline, of course, in short-term memory loss. You'll see some issues with reasoning and judgment. See some communication issues, and then maybe even some issues with being able to carry on one's hygiene and what we call our ADLs, being able to stay on top of and remember to take care of all of our activities of daily living. As we venture into the middle stage of Alzheimer's, which is also called moderate or mid-stage Alzheimer's, the person experiences severe cognitive decline. This is where we see severe communication issues. We see severe decline in reasoning and judgment. We see bowel and bladder incontinence. We see an effect on eyesight and vision. And you can even start to see that walking imbalance with ambulation. There's that shuffling gait that often develops, and facial grimaces. You might see the person just has a weakening of the muscles in the face and inability to control the grimaces. Oftentimes because of this, it makes it really tough for us to understand what the person's saying to us and what they're trying to tell us, what we need to be doing for the individual and what their needs are. This is when a lot of the behaviors set in, and different. When we say behaviors, we mean the actions of the person who has the disease and that are unusual for the individual in their normal cognitive functioning. So we'll talk about behaviors in just a minute. We also have the late stage Alzheimer's individual, and that person is very severely cognitively impaired. Most communication is gone by the late stage. Ambulation has declined. Incontinence has set in. There's a lot of sleeping. There's a lot of facial grimace. Not a lot of activity. However, we can never assume what the person can hear or see, or smell or feel. And with respect to that, we need to always be cognizant of how we talk to the individual and how we treat the individual. Activities professionals will often organize activities that are sensory-related activities, so that those activities will stimulate the sense of smell or the sense of taste, the sense of touch, maybe the hand massages, baking cookies and having the individual present so they can enjoy the smell. Alzheimer's disease affects the sense of taste, but the one sense of taste, that one taste bud that it doesn't seem to affect is that sweet taste bud. So it's not uncommon for you to have patients or residents or your clients who they'll eat their chocolate cake before they eat that steak, and it's because that's a sweet taste that they can easily taste and enjoy, while the steak, however it might be delicious to us, if the person with Alzheimer's is eating a piece of steak, it might feel like just a weird texture that they're moving around their mouth, and they will be more inclined to spit it out or hide it in a napkin, or because there's the lack of the ability to taste. So diagnosing Alzheimer's disease, when someone experiences issues with their short-term memory and other functioning, the doctors that they go to, hopefully they're going to a physician who is very knowledgeable with Alzheimer's and dementia. The Alzheimer's Association shares all literature that we have with our physicians so that we can keep them abreast of different changes in research and development with Alzheimer's disease, so that they can understand what the symptoms are, what the behaviors are, what the family needs. Having an early diagnosis is what we promote to families. We want them to understand what Alzheimer's disease is so that they can know what to look for, so that doctors can rule out other conditions, such as the ones that we saw on the previous slide. Families will have more time to plan for the future if a diagnosis is made. Treatments can start earlier, and they can even be more effective. So the earlier you implement the treatments for someone who's experiencing short-term memory loss, really the longer that they have to spend with their family to make those decisions regarding legal issues, regarding their health care, and just have the most advanced quality of life as possible. So moving on to the way that we diagnose Alzheimer's disease. After those reversible types of dementias are ruled out, doctors can look at the history from the patient, relatives. They can get information from friends if the friend's capable of giving that information. Doctor will also do the complete physical. They'll do a neurological exam, one or more exams. And here's a list of the different types of exams that you'll see common. Mini mental status exam, the MMSE, also neuropsychological testing. Although we can't see Alzheimer's disease in the brain through just a regular CAT scan or an MRI or a PET scan, there's a recent release for a substance called Amyvid, A-M-Y-V-I-D. And it's a dye that can be given to someone that illuminates the brain. And as you can see in the illustration, the dye will illuminate and turn the beta amyloid and the tau proteins. It'll highlight those proteins in that yellow color, and it'll illustrate where the Alzheimer's disease is. So that actually just happened this month. I'm not sure when they're going to actually put this in effect where people can have that dye injected, but just a testament to the research that we're able to do so that we can advance our studies and understand what's happening. So this is a list of the things that the doctors will use to diagnose the person with Alzheimer's disease. Medications that they might prescribe include, how many of you know Aricept and Excelon and Razidine or Razidine, depending on what region you're from. These are cholinesterase inhibitors. They work on a certain neurotransmitter in the brain, whereas your Namenda works on another neurotransmitter called the glutamate regulator. Now, often a doctor will prescribe the person with both of these drugs so that they can work hand in hand and help the individual to increase their cognitive functioning to the highest possible capability. And what we look for is to maintain that functioning across the spectrum as long as possible, slowing the decline of the person's functioning. And that's what those medications do. Antidepressants for those individuals who experience depression, which is not uncommon. It's not uncommon to have a patient or a client or your loved one who's diagnosed with Alzheimer's to also become depressed. I mean, think about it. If I'm certain that if I started having memory loss, that I would know that there was something going on. I would understand. Even if I didn't verbally admit it, I would understand something's going on, and that would be very scary to me, as I'm sure it would to you too, and that can certainly cause depression. So antidepressants can help with the depression. Anti-anxiety medications such as Xanax and Klonopin, Valium, Ativan. These medications just help with what we're called the behaviors that are associated with Alzheimer's. So these can help to reduce the anxiety that the individuals feel because of the confusion of not knowing where they are and not knowing who they are and not knowing what's going on. And then for your more advanced behaviors, you have your antipsychotic drugs that are implemented, the Risperidol, the Zyprexa. That's a very scary one, but a lot of times, depending on the person's, just depending on their chemical makeup, it does different things work for different individuals. Seroquel is one that you'll notice, you'll recognize, and Geodon. And these, again, just help with that side effects of those behaviors. So moving on to other treatments that we can implement. And these are going to be treatments that are definitely worthwhile in the residential care community, also in the in-home care environment where a professional goes into the home and takes care of the person who's still living at home. By identifying and understanding what that symptom is, that's going to help you to be able to redirect the person to something else, to get them involved in some activity, to talk with them, to do those sensory stimulating activities, all kinds of different things. We want to make sure that non-pharmacological treatments are implemented before just simply popping a pill. As I mentioned earlier, the quality of life is so important for a person with Alzheimer's. So being able to offer them the highest quality of life and not just keeping them drugged all the time unless it's absolutely necessary. That's what we definitely want to promote. Learning the appropriate responses to their symptoms, which I'll talk to you about in just a minute. Understanding what to do and what to say when they have these unusual communication issues and these unusual behaviors. Understanding the cause. What's triggered this person's behavior? Is it sundowning? Is it, and sundowning I'll talk about again in a minute as well. Is it the change in the caregiving environment? Is it the lack of socialization, the lack of activities? Is it inappropriate activities? You know, am I an individual who has been asked to sit down to a table where we're playing bingo, but I don't understand how bingo works, or I don't understand dominoes, or I don't understand Scrabble, or and that's something that we have to keep in mind, all of these things. And if we understand all of these issues and how to redirect and how to prevent the different confusion and behaviors from happening, then we can help treat the person without having to implement medication. Medication should be the last treatment, if at all possible. Implementing something else beforehand, and then of course, as I mentioned, it does definitely provide for a better quality of life. I want you to understand that caregivers, now this includes family caregivers and professional caregivers, you guys really, really, really suffer greatly from caregiver stress. Caregiver stress can affect you physically, emotionally, psychologically, and socially. It can really take a toll. 20% of family caregivers currently suffer from depression, and 40 to 50% will not be able to continue to care for the person at home because of the stress that happens as a result of taking care of someone with Alzheimer's. This is where the professional caregiver comes in. 70% of persons cared for with Alzheimer's disease, they live at home. They are still living at home and under the care of a family caregiver. So it's easy to understand how that family caregiver is absolutely overwhelmed with grief and anxiety when they come to professionals for services and for education. So now I mentioned professionals can suffer from caregiver stress as well. The burden and the burnout absolutely affects us, and we want to be very cognizant of this so that we can be sure to implement things in our lives to keep us happy and keep us grounded and keep us functioning healthy. Take time for yourself, even if it's a bubble bath, even if it's that pedicure, if it's a bowl of ice cream, which of course would be made with low-fat or skim milk, and getting plenty of exercise and things like that. So common stressors that caregivers experience: denial and those behavioral changes, insomnia of the person and the caregiver. It really takes a physical toll, and it can cause emotional issues. The individual who cares for someone with Alzheimer's will experience the grief process. And the grief process is not just a process that happens when someone has passed. It happens in Alzheimer's disease from before the diagnosis to well after the person has passed. So Patty Davis is Ronald Reagan's daughter, and she wrote a book called The Long Goodbye, and that's definitely, I think, a great way of looking at what happens to the loved ones of persons with Alzheimer's disease. They have to actually watch their loved one fade, and it's a very long grief process. So financial stress is not absolutely not uncommon. It's very obvious that it's very, very expensive to take care of someone with Alzheimer's disease. In fact, in 2011, the United States of America spent $200 billion in caregiver expenses. That's out-of-pocket expenses. $200 billion spent taking care of people with Alzheimer's disease. And that was not paid by Medicare or Medicaid. It was not paid by the government. It was paid out of our pockets. The families and the professionals who work on weekends and unpaid time, simply put. Driving issues and wandering are definitely stressful for the caregiver, and we'll talk about those in just a second. So I want to explain to you about the term behaviors, and I mentioned to you earlier that they are present in individuals with Alzheimer's, and it's an unusual thing that happens that normally we would not experience ourselves. It's a form of communication. If the person is unable to verbally communicate and their expressive communication has been affected, their ability to tell you how they feel, their ability to understand what you're saying to them, which is the receptive communication, that's going to cause a lot of anxiety, a lot of confusion, so it wouldn't be uncommon for the person to behave unusually as a result. Behaviors are an expression of an unmet need. What does this person need? Let's look at this picture here, and you can see that this lady, she has her hands on her forehead. She looks very upset. She could be crying out. She could be in pain. She could have a headache because her hands are placed on her head. However, what if she's confused and she actually has a UTI and that signal did not pass from the brain to the hands for her to caress her belly because her belly is hurting? Instead, she puts her hands on her head. So being able to understand what these behaviors mean and communication is very, very important for the professional. In the next slide, we'll talk about common behaviors and communication challenges. You'll see a lot of wandering, which is the most common behavior associated with a person with Alzheimer's disease. Aggression and anxiety and confusion. Repetition, repeating the same story over and over and over and over again, which can cause stress. It can make you very agitated and upset. It can make that person upset. It can make yourself upset. It's just really hard to sit and listen to the same war story 3 and 4 times in an hour. But it happens, and they can't help it. If their short-term memory is affected, they're not going to be able to recall that they just told you the same story They're going to be able to pull from their long-term memory bank more easily than from short-term memory, and that's why we're seeing people act, we're seeing them identify themselves as being younger. They feel like they're in their 20s or their 30s, and they're looking for their kids who are still in grade school rather than recognizing the adults in front of them as being their kids. So this is what happens when the short-term memory is impaired, and the person can better pull from their long-term memory. Hoarding and hoarding things. Now this is something that's interesting. The majority of the individuals with Alzheimer's today are your war veterans and your folks who lived in the wartime. So during the time, the Depression era, if you will, obviously people did not have much. I hear stories all the time from the older individuals who lived during that time that they rationed everything they had. They pinched pennies. They were very, very mindful of their finances and of their goods and resources. And so what happens is if they develop Alzheimer's disease, they might remember that there's that need to hold on to things, that anxiety of, oh, what happens if I lose this, and then to just gather things and hold on to them. So it's not unusual to see that happening. Hallucinations and delusions, not uncommon. If the person starts hearing things or if they start seeing things, that's not uncommon. Again, you're talking about a physical disease of the brain. Anytime you have the brain affected in those regions that controls our judgment and our reasoning, it's not uncommon for us to experience delusions or hallucinations. I was about to point to sundowning, and I just want to tell you, for those of you who don't know that term, sundowning is a term used for the time of day in about mid-afternoon as the sun is starting to set, the light's changing, the shadows are changing, and how the shadows are cast along the ground. And it can be very upsetting for the person with Alzheimer's. It can cause lots of confusion, a lot of anxiety, a lot of acting out. I used to always say I worked at an assisted living that specialized in Alzheimer's and other dementias. So I used to always say that it was always a party on second shift, because second shift was coming in at 3 o'clock, and it was just really hard for all of that activity happening at the nurse's station, and then, of course, the time of day changing, and the individuals would just really, with Alzheimer's, would really have a hard time. So that's what happens in sundowning. And also, we think that sundowning is related to the that need to fulfill former commitments. If that person is living in the past, they still think that they're young and have young children, they're still looking for home and things like that, then around 3 o'clock and 5 o'clock, it was a really busy day for them. They were picking up kids from school. They were clocking out from work and going home. So it won't be unusual for you to see a person with Alzheimer's acting out in those ways, and requesting to go home and requesting to go pick up their kids from school and things like that around late afternoon. Inappropriate sexual behavior. Definitely something that happens because there is a part of the brain that controls it controls our impulses. I'd like to call it let's call it our sensor, or our mother, rather. It's the part of our brain that tells us what's appropriate to do and what's appropriate to say and what's not appropriate to do or say. Alzheimer's disease completely eats away the filter that holds in all of those things that we go through life and we absorb. We hear ugly words. We hear prejudices and racial slurs, and we hear all these things, and we see inappropriate sexual behaviors, and we might unfortunately experience a sexual behavior that's inappropriate, and we log all of this into that sensor in our brain, and it tells us how not to respond and what not to say. Alzheimer's strips the filter. What comes up comes out. I remember my pawpaw, the former preacher. He used to cuss like a sailor. We'd play Scrabble. He'd start playing dirty words on the Scrabble board, and it was because his sensor was affected, and he He simply couldn't help it. Let me just stop and address. I have a question that asks me what is the weight of a normal brain and how much shrinkage occurs. And that's something that I will have to reference and to give you that answer. I am unsure of that, but I will definitely write that down and reference it. So we're cutting close to time, so I want to move right along. And I mentioned to you earlier, receptive communication and expressive communication are the two types of communication. They are both affected by Alzheimer's disease. The person is not as their ability to understand what you're saying and their ability to speak is definitely affected. Remember I talked about the toothbrush. As you can see, a normal person's brain activity and the person with Alzheimer's brain activity is totally different. So when we have those plaques and tangles affecting the brain, it's not uncommon that we might pick up our toothbrush and brush our hair, or go to sit down in a chair that's 2 feet away and then fall on the floor. So keep in mind, professionals, as you're approaching the person with dementia, and to always approach from the front. The person's eyesight has been affected by Alzheimer's in such a way that it almost looks and feels like macular degeneration, and that peripheral vision is definitely impaired. So approaching the person from the front is always better than to sneak up on them from the side or from the back. It can cause them to jump. It can cause them to throw their fist and hit you. And being aware of your tone of voice, your body language. Remember, if the person can no longer verbally talk to you, then their sense of being able to understand and relate to nonverbal body language is going to be increased. So they're going to be able to really read your facial expressions, really read your body language. So approaching them with their your arms crossed, across your chest might make the person feel like you really don't want to be there and don't want to be taking care of them. So be real cognizant of both your facial expression, the eye contact that you keep, since you want the person to trust you, and be cognizant of your body language. Also, calling an individual by their name so they understand that you're talking to them, and then addressing yourself and introducing yourself as who you are. Now, you might have the same list of residents and patients and clients that you take care of each day, but from day to day, that person might not remember who you are. That's why it's always good to wear a name tag. It's always good to approach, hi, Mr. Smith, I'm Amanda, and I'll be taking care of you today, just to remind them of who you are, just in case they don't remember. And speaking slowly in a friendly tone of voice. You might have to speak louder if the person has hearing issues, but you can still speak louder and you can still have a nice tone of voice when doing so. Be careful about touching the person. I know that we live in the South and we are touchy-feely, good old Southern folks. But you know what? A lot of your residents, they might not have grown up in the South. They might not be from the area, and they might not be good old touchy and feely. So really understand that person's personality that day and understanding how they're feeling that day before you actually, pat them or hold their hand. It might just save you a blow to the jaw or a pull on the hair. So I see another question. Is it possible for a person to have sundowning and not have Alzheimer's? Yes, it is possible for sundowning to affect all of the other types of dementia. It's also possible for a person to have sundowning if they have those reversible types of dementia. The time of day just becomes very confusing for the person who is experiencing these issues. So yes, it is common for someone to have sundowning who does not have Alzheimer's. Is intervention necessary? These are questions that you as the professional should ask yourself. If you have a person who's having an issue with different behaviors and different things are happening, ask yourself, does the behavior significantly violate other people's rights, other people's health, their well-being? If they're pacing the floor, if they're just chanting or constantly saying the same thing over and over again, is it really violating the other person's rights? Is it really hurting anyone? Probably not. You might as well just let them walk, let them repeat themselves, let them sing. Does the person pose a threat to their own safety or the health or well-being of someone else? Are they throwing themselves? Are they at the walls or at the doors? Are they constantly exit seeking and pushing on the door until the alarm releases and then they're eloping? If this happens, then yes, intervention might be necessary. But if they're just pacing down the hall, just kind of walking around, enjoying the scene or looking for whatever's familiar, just let them walk. Does the behavior make it more difficult to provide care? Bathing. Bathing is an issue for almost everyone related to Alzheimer's disease. Can I not bathe this person? Can I not help them dress? Is this behavior helping, is it impeding on my progress as a caregiver and being able to take care of this person? And then you would want to decide if intervention is necessary. If you can answer these three questions, then you'll be able to understand. And these are also things you should share with family members. Families go in and into residential care communities, and they visit their loved ones, and they're really confused as to why their roommates and their neighbors are just walking around and pacing and chanting and repeating themselves, and it could be upsetting to a family who doesn't understand it. So you might have to say, you know what, as long as they're happy, as long as they're not violating the rights of other people, this is a normal part of the process, and we just let them be happy and let them come and go as they please. And if they need more information about what happens and what causes all of these things to happen, I'd be glad to talk with them. So please refer them to the Alzheimer's Association to educate them. Looking for the triggers we talked about earlier. Different triggers can cause different behaviors. There are environmental triggers, the change in environment. There are physical conditions. There the complexity of the task at hand, and then there are those frustrating interactions that can happen for the person with Alzheimer's. Environmental changes, I'll give you a list here. If the environment's noisy or if there are odors, if there's poor lighting, all of these things can cause the person significant confusion. In the interest of time, we'll move right along. I apologize. I have so much to tell, and I'm so excited to tell you that I run short on time sometimes, but physical condition, is the person in pain? Are they thirsty? Are they hungry? Have they been up all night pacing the floor? Are they having those medication reactions? Those can definitely cause some behavioral outbursts. Complexity of the task. Are we asking them to do things that they are unfamiliar with, or too many options? They can no longer do themselves. Now, we want to let them do these things as long as possible, as long as they can do them, only offering assistance. Doing it for them is going to cause them to not be able to remember to do those things, and it's just really it's an injustice to them. I do see a couple of other questions up, so I'm going to answer those at the end of the presentation if it's okay. Moving along. Just a checklist of communication dues. I want you to remember, please get the person's attention. Please use short and simple and familiar words. I know different generations speak different languages, and young people might speak a different language than old people. And when I say old, I say in 30s and older. I know that the younger generation is the 16 to 25. They have their own way of speaking sometimes, and this might not be something that's the person who's in their 60s or 70s or 80s can really understand. So give one message at a time and speak slowly and clearly. Definitely wait for responses. Asking those close-in questions like that require a yes or a no answer are always best. But offering suggestions like it's time to eat. Come on, let's go have lunch. Let's go have dinner, or let's brush your teeth. Offering those things for them, because a lot of times if you ask someone with Alzheimer's do you want to have lunch, they might not remember that they're hungry, or they might think that they have already eaten, or they might be unsure as to whether or not they can afford to have lunch. They're really, they might be really concerned with finances and whatnot. So you want to just offer the suggestion rather than the question. Also keep in mind that you definitely make an effort on what the person's trying to say. If you if you're taking care of someone who is having trouble telling you what, spitting it out rather, like I am right now. They can't spit it out. They can't get that need. They can't tell you what they need. Then guess what they're trying to say. Ask them to repeat themselves, offering guesses. Just some do not do's, some things to keep in mind. And again, I see a hand raised and I see a couple of questions, and I will address those in just a minute, please. Please avoid quizzing the person. Asking them, don't you remember we just had lunch? Well, no, they don't remember. Their short-term memory is gone. They're not going to remember that they had breakfast. Reminding the family members of this as well, reminding them that it's very, very upsetting to the loved one for them to constantly quiz. Don't you remember I just visited you yesterday, Daddy? Don't you remember that, I just came. Don't you remember me? Don't you remember? Well, no, they don't remember. So avoid arguing. Arguing is going to give you a headache. It's going to cause upset for the person. It's going to give you a headache. It's not good. Validating that person's reality and avoid reality orientation for the individual with dementia is going to make your life and your job so much easier. Just validate what they're saying. Yes, of course. We're going to go home. I'm going to take you home and take you to see your husband, who's probably been dead for 25 or more years, but you don't tell them that because they are not living in our reality. They're living in their reality. And it's just dignified to confirm and validate their reality in a way to have them less upset and to make them feel secure. Responding to the behaviors, again, this is just a reminder to use your memory aids and not argue. Respond to the emotion, not the behavior. Respond to what the person is feeling, what that trigger is, and rather than just the behavior. Acknowledge their requests and respond to them. Even if it's, okay, we will, but right now let's go do this, and redirecting them to something else. Exploring your solutions and consulting with a physician or your nurse if there are behaviors that are getting out of hand and they're such that you can't redirect from, you can't help even with medication. Remember not to take things personally. Remember that filter. I'd really love for you to remember that analogy of that filter. It will really help you understand why the person's behaving the way they are. And then caregivers and nurses, share your experience with others. If you're changing shifts and you're going from one you're passing along your client to another social worker or another caregiver, tell them about what works. Those chocolate chip cookies will get her into that bathtub, and she'll let me bathe her from head to toe. Just keep chocolate chip cookies on hand. Whatever works. Share your experiences. And redirect. Redirecting the focus onto something else is going to help make your job so much easier. Asking for help from the person to make them feel useful. Sure, we're going to go home, but right now, why don't you help me fold these clothes so that I can, so we can get out of here faster. Why don't you help me come and make an errand and run and do this so we can go do this? Why don't you sit down and right here and wait for just a minute, and I'll be right back to get you. And then hopefully we'll redirect them their attention. So I'm going to leave all of that with you in addition to the programs and services that we provide, other programs and services, in addition to education programs like the one that I compiled for you today. We have support groups where we offer care consultations for the family, information and referral hotline, which you probably hear going on in the background because we're just able to reach out to so many people who call our 1-800 number. We have a caregiver timeout program for select counties in my region and in other regions in Georgia. We have a resource library. That hotline, please jot it down. You can use it 24/7. Give it to the families. Tell them to use it 24 hours a day, 7 days a week. If they call within the hours of 8 o'clock and 5 o'clock, depending on their area code, they'll be directed to the region closest to their home, and they'll be directed to someone such as myself who will be able to help them. So I am going to answer a couple of questions here, and then we'll open up the lines for just a couple of questions before we move to the last slide.
Amanda, wonderful training.
Thank you.
Before you move on to the questions, would you advance it to the last slide so they can write down the information about where to do the post-test?
Okay. There's your link for the post-test.
And then we're going to you can answer all the questions that are already on the screen, and then we'll unmute the line so that they can raise their hands. Okay.
All right. Well, I'll answer. The next question I saw was what was the name of the dye that attaches to the proteins? That's Amivid. A as in alpha, M, Y, V as in Victor, I, D as in Delta. Amivid. That's the name. Go to our website, www.alz as in zebra.org, and you can access the information about that. In caring for a parent who is threatened, let's see, what is the best way to, okay. If you're caring for a loved one who is threatening anyone, or they're suspicious, they're paranoid, things like that, definitely addressing the situation as, you know what, I'm sorry that you feel this way. I understand that you're upset. However, I know that person's name did not steal. I know that I saw this thing. Just coming up with a guess or an answer that's going to really help to redirect their focus. You know what, I think I saw that $20 bill, and I think I put it back in your wallet. Or you know, well, I understand you're upset. We'll make sure that person doesn't come around any longer. We'll make sure we sit down with them, or just any kind of an explanation. And if they continue to be upset and paranoid and acting out and things like that, might be the need for an anti-anxiety medication. This might be a time to talk with a doctor about what's happening and what their suspicions are, and that they're upset and they're anxious, and let's see if we can get something to just take the edge off if all the redirecting that you try doesn't work. So I hope that answers that question. Are there regulations and process for assisted living homes specializing in Alzheimer's disease? Yes, there are regulations for assisted living facilities who care for people with Alzheimer's. The regulations were passed last year, and if you want to, I guess the easiest way to access that would be Google Georgia Assisted Living Regulations, and you can find all the links to where you need to figure out those regulations and what they are. I can tell you that any assisted living who takes care of someone with Alzheimer's has to be secure. They have to have locks on the doors. They have to be secure. And let's see. Okay. I think that answers those questions. Now, if we'll go ahead and unmute the lines and have some other questions.
The conference has been unmuted.
Okay. Go ahead with your questions one at a time.
If you have a question, just tell me who you are and what your question is.
If you'd like, you could use the hands raised feature. We will call your name, and you'll know it's your turn.
And if you're among the four who ask questions and maybe I need to answer them a little more thoroughly, then please ask. I'll be glad to see that.
Brenda Colbert.
Hi, Brenda.
Hi. I'm on Karen Baer's computer here at ARC.
Okay.
And I asked a question about the possibility of sundowning without having Alzheimer's.
Yes.
Okay. If you have sundowning but you don't have Alzheimer's, are you considered to have another kind of dementia, or is it some type of mental illness? What is it? Which one is it?
It could be either or. Mental illness does cause symptoms that, especially in older age, that are similar to sundowning, as well as other dementias. So definitely having a doctor check out the individual. If that person has not had a diagnosis of dementia or of a mental illness and they are experiencing sundowning, then they definitely need to see a doctor. Because something is causing that judgment and reasoning issue.
Okay.
Yes, ma'am.
Thank you.
You're very welcome.
Are there any more questions? I want to thank you, Amanda, for a wonderful presentation.
You're very welcome.
And I want to remind everyone to please copy down the SurveyMonkey link so that you can take your post-test if you're not at your regular computer. Everyone have a great day. Thank you.
Thank you.
Thank you so much.
Thank you. Please stand by.